It has started.
Good evening, everyone. Thank you for joining today's C-Surgeries webinar on the topic of surgical ergonomics. Our title, as you can see, is Solving the Surgeon's Posture Problem, Loupe Choice, and Other Strategies for Long-Term MSK Health. A little bit about me. My name's Geeta Lal, and I'm an endocrine surgeon. I hold emeritus status at the University of Iowa, and I got interested in this topic because of my own journey with musculoskeletal injury, which I share on my website in case you're interested. As a result of that, I helped co-found and was the inaugural president of the Society of Surgical Ergonomics. It was formed in 2021. I also work as a speaker, consultant, and ergonomics coach, along with my partner, Linda Miller here, who you see in this picture. She's a certified ergonomist and occupational therapist. I also host a podcast on the topic of surgical ergonomics. So just by way of another introduction, today's webinar has been sponsored by Q Optics Loupes. And if you saw the registration, you know they're doing a Loupes giveaway as well. So let's jump right in. I wanted to share something about Pose Checker with you. So Pose Checker is actually a vision-based markerless motion capture software, and it uses AI-based computer vision algorithms to track body movements for ergonomic analysis. It was actually developed by my partner's company, EWI Works, and there are many of these on the market, but we've been refining this for surgical work, and you can see this is an early video of me, trying to deliver a thyroid out of the thorax, and you can see that my neck is perpetually in the red zone. So the good thing here is that you can use any sort of camera. You don't need any sensors or equipment. This video was taken with a phone camera. And the good thing is that it increases awareness of harmful postures and then also helps you assess the impact of interventions. You can see what's happening with the resident's neck, my neck. I'm going to use this throughout the talk, so I wanted to just share that with you. So let's start off with a definition. What do we mean by ergonomics? Well, the International Ergonomics Association describes it as a scientific discipline concerned with the understanding of interactions among humans and other elements of the system. For us, it's us in the operating room, so the operating room table, our instruments, all of the screens that we use, all of that is what we're interacting with. Another way to look at it is that it is actually also a profession that applies theory, principles, data, and methods to design in order to optimize human well-being and overall system performance. So you might be wondering why we are having a webinar on this topic. So why should you even worry about ergonomics? So here's some data to pique your interest. When I developed my injuries, I was interested in seeing what the literature said about the scope of the problem. And there are many different studies. They're all survey-based, but this is a meta-analysis of the largest sort of number of studies together, over 40 articles and over 5,000 surgeons. And about 70% reported pain from operating. This is multiple specialties, but did not include GI docs and interventional cardiologists, so only surgeons. But what was interesting is that not only pain, but surgeons reported other symptoms that sort of fall under the umbrella of work-related musculoskeletal symptoms, such as fatigue, numbness, and stiffness, with a fair amount of frequency. And if you looked at the common sites of pain, they were the ones that we're all familiar with. So back pain and neck pain about equal, 48 and 50%, and then arm and shoulder were usually lower. 43%. You have to remember that this is all comers and it can vary slightly based on specialty. Now, many of you will say, well, this is survey data and, Dr. Lal, this is going to be inherently biased. And how do we know that this is kind of the true rate of incidence of these symptoms? And so I want to share with you that the numbers that I showed on the last slide are actually also supported by objective measurements. This is actually a study out of the Human Factors Lab at the Mayo Clinic by Meltzer and colleagues. And as you can see, it was published in JAMA Surgery. And in this study, 53 surgeons across 12 different specialties underwent continuous wearable posture recording. And this was done over 100 cases. And overall, what they found was that surgeons spent 57 plus 8, 65% of procedure time in high risk neck postures. This is based on that posture recording device. So when there's increased risk of injury, that's what you were going to see. And the corresponding times for torso and shoulder were 31% and 11% respectively. Now, this study also had a survey component, and what was interesting is that the surgeon's self-reported pain was actually predictive of the ergonomic risk that was picked up by these sensors. And so, what it tells us is that the subjectively reported sites of pain in the survey studies actually do have objective correlates. And so, contrary to what we might have been told in training sometimes or heard around our corridors, pain is not a sign of weakness leaving the body. Pain is a sign that something's wrong and that we need to pay attention to it. So, what's the effect of work-related musculoskeletal symptoms among surgeons? So, the obvious one is the effect on career and workforce. A different meta-analysis actually showed that 12% of people who reported work-related musculoskeletal symptoms, this is among surgeons, needed one or all three of these. So a leave of absence, practice restriction or modification, and early retirement. So roughly 1 in 10, right, of people having symptoms. And if we think symptoms are ubiquitous, they are, depending on the studies, they're anywhere from 70% to 95%, right? So just, think about those numbers. We're not told that when we start. Now, the impact of these things on our personal finances, finances of the institutions we work for, and access to care for our patients cannot be overstated, especially in a time of looming surgeon shortage. But the effects go far beyond work-related musculoskeletal injury, leading to loss of productivity, career longevity, finances. It affects other areas such as well-being and burnout rates. There's good data to support that. There's some studies to show that it's affecting recruitment into surgical specialties. It affects how we interact with other members in the OR. So it affects teamwork, our relationships, our personal relationships, as well as our work relationships. And then there's also emerging data and models to show that it can affect patient safety and the quality of care we provide. In fact, about a third of surgeons in that meta-analysis reported taking their symptoms into account when they decide which procedure to offer a patient. Now, something I learned through my journey working with various physical therapists and occupational therapists and ergonomists is something that I want to share with you today. And this is something called forward head posture, which is pretty much the root cause of all the symptoms that we have as surgeons and why we end up having pain and musculoskeletal disease. So this is actually shown really well by this article. It's a little bit old and it actually is referring to the epidemic of text neck with all our mobile devices, but it's really applicable to surgeons. And what it shows is that even with a mild degree of neck flexion, let's say 15 degrees, you've essentially doubled the weight of the head at the top of the C-spine. And if you think about like when we're using headlights and loupes, I mean, we're well beyond 15 degrees, and then we wonder why our neck hurts, right? But then this is a cascading effect. Unfortunately, it's not just the head. So what happens is you start to get compensation in the body because everything likes to be balanced. And so with this exaggerated forward head, the thoracic spine kind of starts to adjust and maybe tilts a little bit backwards. And then to compensate, the pelvis moves a little bit forward. And I'm really simplifying these things to make a point. And the point is that then these imbalances result in muscle imbalances, which physical therapists will call upper cross syndrome and lower cross syndrome. And as an example, what the upper cross syndrome tells us is that the muscles in the front, where we're kind of rounded our shoulders, these muscles are tight, and the muscles in the back of the neck and upper back are weak. And then that's what then results in kind of a degenerative disc disease as well as, excuse me, herniated discs. And the same thing happens in the lower back. So this is kind of the root cause. And once you understand this, then, we can understand how to prevent or maybe start working on improving the situation. So that was a bit of background. Now I want to delve into why surgeons actually have such high rates of injury, and because we don't usually think of ourselves as a profession that's prone to that kind of high risk of injury. So let's delve into that a little bit more. So first off, I want to share some ergonomic principles that you'll see, talked about, read about, and we need to work in neutral postures. We need to keep things in reach. We need to minimize pressure points, minimize fatigue and static load. And then here's just another video of this is post C-section. A surgeon that I was coaching was closing the incision. And you can see again, even in this short video, the neck never moves out of the red zone. And someone's trying to hold up the pannus, which doesn't help, right? So we tend to disobey these principles in our daily work multiple times. And it's not that it's not intentional, it's just that we're focused on the task we need to do. And so we don't think about these things. The culture of our profession is another contributing factor. What do I mean by that? Well, there is such a thing as a surgical personality. When, we're taught to push through, we forego breaks, we accept our symptoms as part of the job. And unfortunately, some of these traits are ingrained and then they happen to get reinforced during training and practice. And so the net result, unfortunately, is that less than 5% of us report symptoms to institutions or our superiors, let alone anybody. And then less than a third of surgeons will actually seek treatment. We're pretty good at self-treatment. Ibuprofen and coffee is pretty much standard diet, right? Then there's a huge issue with kind of our environment and particularly relating to our instruments. So if you think about it, unlike scissors and pliers and other tools that we use in daily life, surgical instruments are actually designed to meet regulatory requirements. Let's say, for example, the need for sterilization, rather than the ergonomic considerations or the diverse anthropometrics, so hand size, grip strength, etc., of the people that are going to be using the instrument. And then not only that, the production and the OR stocks are geared to the common sizes that most surgeons can work with. And this is especially true for endoscopic, laparoscopic devices such as staplers, endoscopic instruments, etc. And as a result of that, smaller handed surgeons, who happen to be more commonly women, are going to report much higher rates of difficulties using instruments. So remember, the definition of ergonomics is adapting the environment to the worker. And here in surgery, we're essentially asking surgeons of different hand sizes. You can see the two fellows in the same training program are expected to use the same instrument, which is the antithesis of what we say ergonomics is about. Not only that, now after our time in the OR, we're documenting in the electronic health record, often in common work areas using laptops, phones, etc. And none of these workstations are set up for us. And so this subjects us not only to strain inside the OR, but also the stressors that you usually see in desk workers. So that's another added risk with the expansion of our electronic medical records. And then we have workspace and time limitations. What do I mean by that? Well, your patient's anatomy cannot be redesigned to optimize the work environment. Unlike, let's say, like in the figure here or in the diagram, you take your car to the shop, they can elevate it, they can take the door down, they can, take various parts apart and put them together. We don't have the luxury of doing that. Patients are unique, and so are the surgeons. And so standardization of tools and workflows is really hard. We all tend to do the same procedure slightly differently. And then on top of that, it's always drilled into us that OR time is money. And so the thought of taking breaks is sacrilegious. One more factor is our adjuncts. And what do I mean by that? Think about the things we use to do our jobs. So when imaging platforms became digital, they got retrofitted into existing OR spaces, which meant that when I'm not flexing my neck forward to work on a thyroid, I have to really extend it because they put the monitors wherever there was space in the room, right? there has to be thoughtful design. Then let's talk about sort of the loops and headlamps that many of us use, foot pedals, which I and other surgeons use, and then those of you who use lead aprons, that is also an added load to the spine. So all of these things, particularly loops and headlamps, have been shown to increase the time spent in ergonomically unfavorable neck positions. And so these are huge contributing factors. You might be wondering, what is it about loops that increases the biomechanical load? So if you look at the design of most loops, right, the magnifying part is going into the glasses part. And what determines your posture is a couple of things. One is the weight and where it is distributed. So most of the time, because the optics are in the front, it's front loading your face. It's not symmetric. So the heavier they are, they're going to put more strain on your neck. The second thing is something called geometry. What do I mean by that? Those of you who've purchased loops know that you've maybe come across something called the angle of declination. What is that? That's the angle at which the magnifying part actually goes into the glasses or the lens when you compare it kind of to the line of sight. Now, the for a standard sort of declination angle, you're going to have to flex your neck forward to be able to see through the magnifying part. So the deeper the angle of declination, meaning the steeper this angle is where it goes into the glasses. So here the declination angle is much sharper, much steeper than this. You have to then tilt your neck forward less, right? So over the years, we saw that loops began to have steeper and steeper angles of declination so that you had to flex your neck forward less. And kind of the end result of that was deflection loops, which I'll talk about in just a little bit. The other things that matter in the geometry are the things that people measure for you, right? They ask you what your working distance is going to be. Where are you going to be standing? Are you going to be looking deep into the chest, or are you going to be looking at something on the surface? That matters, right? Because if they don't set that up correctly, again, it's going to affect your posture. Pupillary distance can affect alignment. And where the frame, how the frame is fitted to your face actually also makes a difference in terms of how the weight is distributed and misalignments that can occur. So all these things matter. So it's important to think about that. Now, enough about sort of setting up the problem. Let's look into solutions. We're problem solvers, so let's delve right into that. I'm hopeful that with all of this, you can have something to take into the OR and start thinking about doing differently right after the webinar, meaning tomorrow. So before we jump into specifics, let's talk about a framework. The Swiss cheese model, it's used extensively in quality and safety and during the COVID-19 pandemic, is really a useful way to look at how to address the ergonomics problem for surgeons. So a couple of key concepts. There is no single smoking gun. So I can't tell you change this one thing and everything will be okay. The point is you need multiple things, just like the pandemic where you needed masks and vaccines and distancing. Here, you're going to need to adjust various things. And so we're going to talk about those. The other point I want to make is that, what I'm going to talk about today is actually personal responsibilities, what we can do as providers and as surgeons. But remember, ergonomics is us and the environment. And so there has to be some shared responsibility, working with sort of equipment manufacturers to improve kind of the fit, for example, of laparoscopic instruments. And then there are organizational culture issues, and maybe we can discuss some of these more in the Q&A. But I just want you to remember that there are these different components. So let's delve into the specific components. So because our risks are both inside and outside the OR, we're going to address both of these in turn. Let's start with the intra-procedural optimization. So the thing you can do is start with setup, right? So here's an example of a video I got from a client or a place where I was giving grand rounds. And this is to show you open surgery, okay? And you can tell that the person wearing the headlight is the trainee, and then their attending is opposite them. This is an open case. And perhaps some of you are already thinking, this person's neck is in the yellow zone, and this is the analysis from the program that I mentioned, the post checker. It shows that their neck, significant amount of time is kind of in a high risk zone. And so some of the things that struck me while watching and looking at this video and watching people operate like that is how you set up for open surgery. Now, these are generalities. I realize if you're in subspecialties, things might be different, but these are just some things to consider. So, a common thing is table height. Where should the table be? You saw there the table was probably a little bit too low for the trainee, so the table height should really be adjusted to the height of the tallest person who's doing the surgery with steps for other people. I stood on steps as a resident. I stood on steps as an attending because my residents were often taller than me. So we've got to break that cultural barrier down. The ideal table height for open surgery is roughly at the forearm level because you want your forearms to be parallel to the floor. So that's a useful guide. Again, avoiding extremes of neck flexion, neck twisting, keeping the shoulders down and relaxed, keeping the upper arm perpendicular, the forearm parallel to the floor, and then really standing squarely on both your feet, engaging the deep trunk and pelvic muscles to maintain neutral posture, avoid kind of twisting the spine. And then if you have foot pedals, you shouldn't be standing like a little flamingo and just have it where you can reach it quickly. Sometimes it's good to even change feet that you're using it with, just so you're not, getting askew in terms of balancing on one foot. Let's take a look at endoscopic surgery. So this applies if you're doing thoracoscopic surgery, laparoscopic surgery, maybe you're doing some GI endoscopy, anything with a screen, right? So here there's a laparoscopic surgery going on. I believe it was kind of an upper GI case. Working around the esophagus and stomach. So you can see here the primary surgeon, their arms are pretty much in the yellow or red zone throughout in terms of the analysis. Remember, this just gives you a snapshot. So, what are the things that we want to think about when we're positioning for endoscopic surgery? Again, this is an exaggerated view on the left, and so some of the things to consider here are the table height needs to be lower. Now, it was pretty low in the last video, but here a rough guide is 70 to 80% of elbow height. For many people, that will come up to the level of the umbilicus or slightly lower, so you'll see that described as well. But the bottom line is because you're going to be holding instruments, you're going to have to end up shrugging your shoulders, so you have to drop the table. But the other principles remain the same. Try to keep your forearms as parallel to the floor as you can. The other thing you'll see is monitor placement makes a huge difference. So if the monitor isn't placed properly, people are going to extend their neck while they're trying to look at it, and then that causes discomfort. So ideally, it should be so that the top of the screen is at eye level, so that you look with a slight downward gaze, 15 degrees downward angle, you can see the center of the screen and have it at roughly about 3 feet arm's length. Now, this is for standard monitors. Obviously, if the monitors are larger, they need to be further away. And then for those of us that use progressives, it's a good idea to get mid-range glasses when you're looking at the laparoscopic screen. Otherwise, you'll find yourself in that sniffing position again. And then just taking care where you place the ports and how your working angles are can make a huge difference. A lot of times when I'm giving these kind of talks, a lot of people will say, well, actually, this is the exact reason why I switched to the robot to get better ergonomics. And robot assisted surgery is more ergonomic because it allows you to sit. The console is adjustable. But if you delve into the literature, actually, studies show that although the back pain rates are lower, you still have a significant amount of neck pain. And there are now new areas of involvement like the fingers and wrists. And you can see that in this particular video that I have of someone sitting at the robot, and a lot of that, as those of you who work on the robot know that it's a lot of that is related to the viewfinder. The newer version is supposed to be better in this regard, but I think we'll have to wait and see what the actual data shows. And then, of course, there are always issues with finding the appropriate chairs for working at the robot. I think that's a huge contributor. But there are some general guidelines. So once you find your settings, make sure you save them or at least take time in the beginning of your case. It'll help throughout the case if you just take some time to find your comfort zone and adjust things to where you need them so that you're comfortable. So, getting a good chair with lockable wheels and lumbar support and enough depth that you can actually sit back and still get far enough forward to look into the viewfinder is important. The same principles apply in terms of, keeping your forearms as parallel to the floor as you can, avoiding sort of that upper back neck flexion, keeping the stereo viewing angle less than 30 degrees from horizontal, and keep the using the clutch to keep your hands and wrists neutral as much as possible, adjusting that armrest again to keep things relaxed. What you don't want is to be doing something like this on the left, sitting forward in the chair without lumbar support and having your shoulders up. Again, exaggerated, but it makes the point. Other things you must have noticed in all the diagrams, there's anti-fatigue mats. There's now good data to show that they actually reduce fatigue and lower extremity pain for all surgical personnel, not just the surgeons, but the scrub nurses and scrub techs as well. It's important to have supportive footwear and use support hose as you need it. There's team running shoes and there's team clogs. Either are fine as long as you feel like your foot is well supported. If you're going to use running shoes, don't use running shoes that you've been using to run for 6 months. Have a pair dedicated for the OR. Instead of headlights, you might want to see how you can do away with headlights, maybe using a self-retaining retractor or using lighted retractors instead of a headlight. Sometimes the suction tip is also lighted. And then when we're moving and transferring patients using technology rather than, person power to move patients. I want to delve a little bit more into the adjuncts because they seem to be a huge pain point for myself and for other people. So general rule is that look for the lightest model, whether it's loops, headlights, or if you're using lead aprons, look for a lighter model and look for attention to ergonomics in design. The second thing is use it for the least amount of time necessary. It took me a long time to realize that I didn't need to wear loops from the beginning to the end of the case until the incision was closed. Did I really need my loops to watch somebody close the incision? No. So once the critical part of my surgery was done, the loops were off. Okay, so that again, over cases will minimize the stress on your neck. Other things to consider when you're selecting something like loops. So think about the type of work that you're doing. You're going to see a lot of ergo loops, ergonomic loops. They're also called deflection loop or prismatic loops. And they've kind of refined that angle of declination that I was telling you about to an extreme where sort of it's like having a mini microscope attached to your glasses. And so you're looking straight forward as I am here, but you're actually seeing the field below. So it keeps your neck straight. So this is what that ergo loop does. And the important thing to consider, though, it's great for this type of work, but it may not be so good for example, if you're trying to do perineal work, that's not going to work, right? These kind of loops. So you may need to figure out what the majority of work that you need your help with the loops is. Type of straps make a difference. This is on a podcast episode I did about loops as well. There's something called a Sir Hermston strap that helps offload the weight from the nose and ears, and you can get them on different kinds of loops. Again, seeing how you're getting fitted for them. If there's customization for your unique facial features, there's a trial period, customer service, etc. The other thing is that we discussed this during that podcast episode as well. Many of us we're still using the loops that we got 10, 15 years ago when we were in training. The thing is, though, our bodies change, including our eyes, and technology has changed. So it's really worth looking at updating your loops as the technology has changed and as our bodies change. So just keep that in mind. I know they're a big investment, and so it's a really important consideration. Other things about adjuncts, for example, headlights. There are many headlights that will now come with kind of lightweight options and different kinds of straps that you can adjust for optimum comfort. So look for those kind of features. Sometimes you don't need a big bright headlight if you're not working deep in cavities. Maybe a small headlight that comes with your loops, with batteries or with cords, you can use that. If you're using lead aprons, two key principles. One is that if you have to use them, use two-piece ones rather than a one-piece one. That way you redistribute the weight on your body. And the second thing to know is that there are many lightweight options that are kind of non-lead. So they're mixed with other compounds or they're completely without lead. And they can be 40 to 50% lighter. As long as they provide you with the same radiation protection, it might be useful to look at those kind of aprons. Now I want to talk a little bit about, as I said, something that's really sacrilegious in surgery, right? Breaks and doing exercises. So breaks are actually a really well-recognized ergonomic intervention in industrial engineering, and they've actually been studied in surgeons. This is actually a landmark study from the Mayo Clinic. It was involving multiple institutions and multiple surgeons, and what they did is they had a non-crossover design and they had surgeons incorporate small breaks and exercises while sterile and then analyzed what they got after that. And to no one's surprise, 88% reported no change or actually an improvement in mental focus, right? One of the objections we have is that, well, if I take a break, it's gonna sort of break my focus. The thing is, it actually helps and may not even change that. So that's important to know. But the other piece was that, again, 100% improvement for physical performance. And the best news for all, including OR administrators, is that actually OR time wasn't prolonged. In my own personal experience, I found that I become more efficient if I take breaks during a long case day where I have a single case running, 10 hours or so. There is a real cognitive fatigue in addition to the physical fatigue. So many of the surgeons wanted to incorporate this into their practice. So Dr. Hallbeck's team and the Human Factors Lab at the Mayo Clinic actually developed an app. She has given me permission to use this QR code, so you're able to access it. It's free to access, and it comes with a timer, and it takes you through a series of stretches. They've been developed in consultation with surgeons, OTs, PTs, and ergonomists. And the duration has been optimized so that it can easily be done. It's like 60 seconds. Now, the timer's set to go off every 45 minutes because you need to take a break in a case that it's extending over 2 to 3 hours. You need to take a break at least after 45 minutes. But if it's not a convenient time in the case, you can pause it just like we snooze our alarms. It's possible to do. The other thing I want to make sure people understand is you don't have to use this app, right? You can use your phone. You can use an opportune time in the case to take a break. Maybe you're waiting for pathology. Maybe you're waiting for some instrument to come up. Instead of sort of mumbling under your breath, as I often do, you can use that time to just run through a quick break and stretch, maybe something that your PT has already shown you. So many ways to incorporate that. A little bit of information for outside the OR, because that is another huge risk factor. Now, physical fitness is really important. And for those of you who do cardio, fantastic. It's great for our heart. We all need to do cardio. But for career longevity as a surgeon, if you think about what I showed you with the forward head posture and that upper cross and lower cross syndrome, what you need is some sort of strength and stretching routine. This will go a long way to extend our careers. And you can incorporate that by whatever means you want. So you can use yoga, you can use Pilates, you can work with a personal trainer, a PT. Come up with a routine that works for you, that doesn't require too much effort. You can do things at home. You don't have to go to a gym. You can do things with small pieces of equipment, and I'll give you some resources where to find these exercises. What is the data behind it? Well, a preventative program incorporating stretching and strengthening outside the OR actually improved surgeons' back pain and analgesic use. So there's good data to show this. That's me stretching in the corner while I'm waiting for anesthesia to do their thing. And I mentioned a couple of resources. So the American College of Surgeons Ergonomics Task Force has recommendations, which include sort of exercises as well to do outside the OR, as well as the OR Stretch app has exercises that you can do outside the OR as well. So I urge you to look at these free resources and take it from there. A note about setting up your computers. So in your home office or in your lab office, you can, again, the same principles apply. It's really important to have a comfortable chair, a chair at the correct height, the table, the desk at the correct height. You can see, forearm parallel to floor. Again, very similar principles. We all love using laptops. They're very convenient, but they're messy for our necks and shoulders. So if you have to use a laptop, I suggest getting a external sort of elevator for your laptop, as well as getting an external mouse and keyboard to minimize the strain on your shoulders. You can switch to voice recognition. And then it's important to pay attention to your ergonomics and postures outside of the OR and everything that you do, whether it's cycling, your other hobbies, gardening, right? This all adds up. A word about culture, right? So we can do and plan all these things, but culture will sort of trump strategy any day, right? And what do I mean by that? So sometimes when people ask for anti-fatigue mats, somebody will say, "Oh, you want the princess pad or you want the sissy pad." Why? Why do we have to use language like that, right? It discourages people from using things that are going to be useful for our long-term health. So we should try to get away from doing that. We should maybe build systems where there's a mechanism for early reporting without sort of penalty. People can get referred to OT and PT. Maybe we should think about incorporating these best practices using an ergonomics checklist and a timeout. Just before we make the incision, we go through a little pre-incision checklist. That's the time where we can also make sure that everybody has, anti-fatigue mats. The screen is set up for your case where it needs to be. Your pedal is where you need it to be. You have, lifts and stools, etc. Think of it as a team sport, and let's look out for each other and promote a culture of wellness. What else can you do? I'm going to make a plug for the Society of Surgical Ergonomics. Again, a lot of resources. Please check it out. Consider joining. You can become an ergonomics champion for your institution and help us with several committees as well. You can think of ergonomics as an area of academic interest. I mean, we're going to have our fourth symposium from the society this year. It's virtual. This is really becoming an important area of study. Ergonomists, engineers, rehab services, you can partner with them. A lot of the investigation field is wide open. So do consider that. And then, of course, if you don't have disability insurance, it's a whole other sort of talk for that, but you need to get good disability insurance early. So, in conclusion, I just want to thank you all for being here today, and I look forward to the Q&A. My contact information is up there, including the QR code to the podcast, if you're interested. And I also, again, want to thank C Surgeries and Q Optics for this opportunity and allowing me to present to all of you today. So I'm just going to take a quick look at the Q&A here. And um, someone has asked, so loops are personalized for each person based on their visual needs and working distance. Indeed, absolutely. Uh, Another question regarding the headlight, do these battery lights last long? Will it last a full workday or will it need to be charged throughout the day? Good question. Uh, I have used them for an entire day. Now, obviously, there are different battery strengths and different light strengths, etc. I think you can discuss that with individual vendors, but generally they do last the OR day. Another question, um, what are the tools of research in this topic? So I think it might be helpful if you're interested in exploring and researching in this topic is really to go to the Society of Surgical Ergonomics website, and you will see the sorts of questionnaires people use to kind of get a baseline of what sort of the work-related musculoskeletal injury is among residents or attendings in a particular specialty, what sort of analyses people do in terms of ergonomics, objective measurements, so REBA scores, RULA scores. So you'll get the basics of those tools there. So I would recommend that you take a look at that as a starting point. Question about what about products like neck spine and their headlight integration? So, for people who are not aware, neck spine is a particular kind of exoskeleton. Exoskeletons are can be active or passive, and the passive exoskeletons are basically using stored energy, so inertia from like spring mechanisms and bar mechanisms. And neck spine is one example that is commercially available. There has recently been a study published about sort of what it helps with both kind of subjective opinions from the surgeons in the study, but also some objective measurements. And it showed that it actually reduces the time spent in high risk neck postures and increases the time spent in less high risk postures. So I urge you to just look at that study for additional details. I'm not sure what you mean by headlight integration, so perhaps if you could type a different question, uh, re I can re answer that one. Do you remember an ergonomics coach in the OR? Excuse me, I'm sorry, I don't understand that question. If you could rephrase it or type it again. I mean, I function as an ergonomics coach. I do it remotely and I can do it uh, uh, in the OR. Oh, recommend. I get it. Okay, so the question is, do you recommend an ergonomics coach in the OR? Well, I think it depends on, what your need is. So I find that, we give talks and myself and other members of the Society of Surgical Ergonomics talk. We do symposia. These are great starting points, but to implement these things, often there are unique things in the place you work. For example, you might decide tomorrow you want to use anti-fatigue mats, and you start to ask the OR to get them for you, and you may find that there's objection because they're not supposed to be used because of infection control protocols. So you have to then get involved with that committee and figure things out. So I think that's where coaching can help. And surgeons do it like me. Several physical therapists, occupational therapists, and ergonomists can do that. Unfortunately, there aren't too many of those kinds of coaches around. But if you want some sort of personalization for your unique MSK issues and your surgeries and your institution, it's probably a good idea. I believe that this presentation was recorded, so you will have access to that on C Surgeries. Please correct me if I'm wrong. Um, Another question. Neck spine is able to have headlights integrated into their exoskeleton with the thought being it reduces the issues you brought up with the headlights. You answered most of the question already. Yes. Okay, now I understand. Thank you for restating that question. Yes, they do have a small headlight along with a battery that can be worn with the exoskeleton frame. And yes, if you don't need, it's not as big as a sort of external headlight, so uh, it's not as bright as those bigger lights. But if that's all you need, yes, it works well for that. Do you have specific advice for ophthalmologists regarding wearing the indirect ophthalmoscope the whole clinic day, even more so than the OR? It is quite heavy. Whom should we reach out to for adjustments? Good question. I am not an ophthalmologist, so I do not know whom you would reach out to for adjustments. Perhaps a place to start would be your representative. My general advice would be, see if there are alternatives that you could use, or models that have more attention to ergonomics. And when you don't need them, don't wear them. That's exactly it, right? Those general principles. If you can replace it with something else, uh, please do that. How or which method stretches do you recommend to prevent or relieve minimal wrist injury or prolonged wrist discomfort during procedures? So I'm unable to answer specific questions on this kind of a general webinar. And as you can imagine, the ergonomics coaching that I do is more geared towards sort of how to change things within your workflow or the expertise that you should seek. So if you were a coachee of mine, I would say if you've got some issues going on, your best place to start is to get a personalized evaluation by a physical therapist. You can get a hand therapist as well, if need be, to specifically address those issues. Otherwise, the resources that I've shown, the American College of Surgeons Ergonomics Task Force, the OR Stretch, the Society of Surgical Ergonomics, you will get wrist stretches in all of them. But if you're already having discomfort, I think it's really important to get evaluated formally by a physical therapist before you start into sort of any sort of exercises. Okay. I've heard different opinions on loops. How do you know if what you are using is actually contributing to the strain? Give me one moment, please. Um, that's a good question. And you'll find that, the ergo loops, for example, the ones I mentioned, the deflection loops, they work well for some people, and others have noticed that maybe it's worse for them. Maybe it's not suited to the type of work they're doing. I think the best thing would be to reach out to your representative, or have someone watch you in the OR. Maybe, what we've done is take videos of people and compare, using the loops, which kind of loops, and see what's happening with their neck. But you could have an ergonomist or a PT watch you with that and see if that is contributing to your strain. All right, I don't see any other open questions, so I think we're almost to the end of our time. Again, thank you so much for being here and for being an engaged audience and sorry, for being an engaged audience and for all the questions. Until next time, thank you.